Welcome to Chapter 28. This chapter will be talking about reproduction. The first thing we need to talk about will be some terminology. The term gonads is going to refer to just the organs that produce the gametes. Remember that the gametes are the sex cells, so they're eggs for the female and sperm for the male, also referred to as spermatozoa and ovum. Remember, these are haploid. Haploid means that they have half the normal chromosomal complement, so they have 23 single chromosomes, not 23 pairs. So the female gonad will be the ovary, and the male gonad is going to be the testicle. There are accessory glands that we'll talk about, some in the male, such as the prostate, seminal vesicles, and then also some glands in the female that assist with things like lubrication and even providing nutrition for the egg and the sperm. And then we'll talk about external genitalia. So the female gamete is the ovum, or ova as plural, and she produces one ovum per month. And I always jokingly say that women are much more efficient than men because they have to produce 500 million or half a billion sperm per day. One of the reasons for the large number of sperm that they produce is because there are so many defective ones. You'll find some that have bends and crooks and double tails and double heads, and so there's a large number of them, but there are a high percentage of that will often be defective in some way. So again, the female gonad is the ovary, and along with producing the egg, it's going to be producing estrogen and progesterone. The male gonad is the testicle. It produces the sperm, but it also produces androgens, in particular testosterone. And if you wonder what's in this picture, this is actually turkey testicles. As you can see by the Bud Light band around the guy's arm, that's a party, and they're having what they call a ball fry. We'll talk about the male reproductive tract first. I like these diagrams that show the reproductive tract sitting within the pelvic canal. I have a similar one for the female. And you can see, I had a friend one time that was crushed by a horse, and it broke this part of the pelvis right here, and it actually did quite a bit of damage to the root of the penis. So testicles come in pairs, and they're located in the scrotum, and we'll talk about the scrotum a little bit more later. It's surrounded by a membrane referred to as the visceral tunica vaginalis. So don't be confused by the fact they're saying vaginalis. The word vaginalis, or vagina, actually comes from the meaning recess. So we'll talk about how this comes about, and I'll draw you a diagram very shortly. It's surrounded by a very thick white covering called the tunica albuginea. The ovary has the same. But the testicle is very densely packed with these tiny, tiny seminiferous tubules to the point of about 1/2 mile per testicle. So these are the seminiferous tubules that you're seeing right here. Between those tubules are cells of Leydig, which you need to know, and they're the ones that produce testosterone and the other forms of the androgens. And the other type of cell you need to know is referred to as a sustentacular cell, also known as a nerve cell or a Sertoli cell. These are actually in the walls of the tubules, the seminiferous tubules, and they line the tubules and they provide nutrition for the developing sperm. On this diagram, you'll see this white tunic, and this is tunica albuginea, and then you'll see the lining of the scrotum, which is referred to as the vaginal tunic. That's the inside lining. That would be the parietal layer, and then you've got another layer on the surface, which would actually be the visceral layer of the vaginal tunic. The purpose of the scrotum is to maintain a proper temperature for the sperm. There's two muscles I want you to know about, the cremaster muscle and the dartos muscle. The cremaster muscle comes all the way down and wraps around the entire testicle and can raise and lower the testicle. When it's cool outside, to maintain a proper warmth for the spermatozoa, the testicle will actually be taken up closer to the body wall. When it's hot outside and sperm need to be kept cooler, then it's going to be lowered. So at body temperature, 98.6, that is too warm for healthy, viable sperm. The dartos muscle lines the scrotum, and it will actually give the scrotum sort of a puckering effect when the outside temperature is going to be cold. Again, the whole purpose of this is to be able to snug the testicles to the body when it's cooler, or to relax and take the testicles away from the body when it's going to be hotter. So there was a thing for a while, I would say probably maybe 15, 20 years ago, a lot of men were reporting infertility issues, and it was diagnosed as problems with the sperm being kept too warm because they were wearing basically the tighty whities and keeping the scrotum too close to the body wall. The other thing that was a big thing back then, a big fad back then, was the use of hot tubs. And so they discovered that men who sat in hot tubs for prolonged periods of time would actually have spermatozoal damage and they would be infertile. So men who run really high fevers, they can have their sperm damaged. And I actually saw a study somewhere that men who wear kilts actually have the healthiest sperm count. I put this picture in because people seem to find it quite fascinating. This unfortunate guy has a case of what's referred to as elephantiasis. It's fairly common in sub-Saharan regions. It's caused by a microfilariae, or a tiny worm-like parasite in the bloodstream that causes fluid accumulation. So people always say, well, where's his penis? Where his penis is going to be actually pointing upward. As you can see, he's in a hospital type situation, so one would assume he's getting ready to be taken care of. So the testicle is the area where the spermatozoa are formed, and they're going to leave the testicle, and the very first part of the reproductive tract is going to be the epididymis. This is a very long, tightly coiled up tube again, and it's about 23 feet long, and this is where sperm will basically grow up. By the time they leave the epididymis, they are mature, but they cannot swim. They are still immobile. As long as they are immobile, they're not going to be able to fertilize an egg. You need to be able to label these diagrams on an exam. So what you're looking at here is going to be the testicle, and that's going to be the location of the seminiferous tubules where the sperm are actually made. And then the epididymis will be stored here in these tightly little coiled up tubules. They will leave the epididymis and go through the vas deferens. They may be stored in there for a while. During ejaculation, they'll be passing through what they refer to as the ejaculatory duct, becomes a urethra, and will exit the body. So make sure you know the pathway. So again, what you're looking at to label the parts, make sure you know the testicle, the scrotum, the epididymis, the urethra. The accessory glands you're going to need to know be the bulbourethral glands, the prostate gland, the seminal vesicle, and also note, while we're on this page, the location of the ureters, and please note the bladder. Now, as far as naming parts of the penis, obviously it's going to be the glans penis, which is going to be the tip of the penis itself, and then the erectile tissue is going to be surrounding the urethra and then above it. So we're going to be having the corpus spongiosum and then the corpus cavernosum, but we'll look at those again later. So looking from the dorsum, again, you're looking at testicle, epididymis, ductus deferens, the bulbourethral glands, prostate gland, seminal vesicle, bladder. And if you note how the prostate gland is surrounding the urethra, that's why as men age and they develop things like BPH, or benign prostatic hyperplasia, they'll end up having problems having a forceful, normal urine stream. The ductus deferens was at one point called the vas deferens, and this is going to be the tube that sperm is going to enter as it leaves the epididymis and heads for the urethra. It has cilia, and the cilia is going to help propel the sperm upward and outward. And it also uses peristalsis. Remember, you have smooth muscle lining these tubes. So sperm can be stored in here for a period of months. So what we're talking about is this tube right here. The ejaculatory duct is only about 1 inch long, and it's basically where the vas deferens goes through the prostate gland and leads into the urethra. The male differs from the female in that the male urethra serves two purposes. It's going to be used for sperm transport from the reproductive system and urine transport by the urinary system. For testing purposes, don't worry about the fact that the urethra is divided up into 3 portions depending on where it's passing through. For the external genitalia, you're looking at the 3 parts of the penis. You've got the root, the body, and the tip, being called the glans penis. That's where you're going to find the greatest concentration of nerve endings. On the body of the penis itself, you're going to have a continuation of the dartos muscle, which lies under a layer of areolar tissue, which is that loose connective tissue that makes the skin of the penis very movable. Sometimes, if the male is not circumcised, there will be what's called a prepuce or foreskin. We'll talk a little bit more about that. So the penis, and make sure you understand this, the whole erection business is coming from the fact that you've got the spongy-like tissue that is very tightly enclosed. And when that sponge tissue is engorged with blood, because it's very tightly enclosed, it's going to make the penis rigid. So here is a photo of the penis with all the other tissue, the non-vascular tissue, removed. You can see just what a vascular chamber it is. This is arterial tissue, and it's divided up into really 3 compartments. You've got 2 that are referred to as the corpus cavernosa, and that's going to be the top area here. And then you've got 1 called the corpus spongiosum that actually surrounds the urethra. So make sure you know the names, and again, be able to identify those on a drawing, on a graphic. The act of having an erection is parasympathetic, and that allows the arterial tissue to open up and be flooded with blood, and the erections. But I want to point out, since this is parasympathetic, if a man is having trouble having an erection, he's going to stress about it. Remember, the stress is going to induce the sympathetic nervous system to become active, and so the more he stresses about it, the less likely it is that an erection is going to be forthcoming. I'm not testing you on penis lengths, but I put this in here because everybody always has questions about it. So if you see, pretty much the non-erect penis is always pretty standard size, and the average erect penis is pretty typical too, so about 5.5 inches or so for an erect penis. And I always put this in here to try to encourage the guys not to smoke. If nothing else can do it, this usually can. You can actually shorten your penis if you're a smoker. That's one of the first things that a physician will ask you if you're having trouble with erectile dysfunction is, are you a smoker? Because again, your smoking is going to be damaging your vascular tissue, and the penis is basically a really fancy artery. So make sure you can trace the pathway of sperm from when they are manufactured in the testicle through the epididymis, ductus deferens, ejaculatory duct, and then the urethra. I hate typos, and I see one right here. This should be an O. I do want you to know the spermatic cord. This is going to be the bundle of tissue that passes through the inguinal canal, and know what's in it: the ductus deferens, nerves, blood vessels, and is surrounded by the vaginal tunic and also the cremaster muscle. So what you're looking at is, this is how the testicle gets into the scrotum. If this is going to be the inguinal area right there, and you've got the peritoneal cavity, what's going to happen, in utero, the testicle is actually up high and is attached by a small piece of tissue referred to as a gubernaculum testis. As a fetus grows, the gubernaculum actually contracts down, and it's going to pull the testicle down through the inguinal canal. And so what's happening is that's going to actually pull a layer of the peritoneum around that testicle, and that's where you get the vaginal tunic. So this entire little bundle right here is going to be called the spermatic cord. So when you have an inguinal hernia, it's going to be because a piece of intestine has slipped through the inguinal canal and is down into the scrotum. That can be beyond painful. It can obviously be life-threatening, because if that piece of intestine strangulates or loses its blood supply, then you're looking at a possible intestinal rupture. Inguinal hernias are often the result of heavy lifting, age, and obesity. I just rearranged some of these slides because this sort of follows what I was talking about Make sure you understand that the testicles start out up in the abdomen, up near the kidneys, and then this little ligament called the gubernaculum testis is going to be holding the base of the testicle into the base of the scrotum, and as the fetus matures, it's going to be contracting because of the increasing level of male hormones or androgens, and the testicles will pass through the inguinal canal down into the scrotum. Now I realize this photograph, this graph did not reproduce too well, but what you're looking at here are the testicles, and they're very large in the fetus proportionally speaking, and obviously it's going to be reduced proportion-wise as the baby matures. But what's happening is here's your scrotum. They're going to descend. In fact, the process itself is called testicular descent into the scrotum through the inguinal canal region. So they're going to end up down in the scrotum. So what's happening? Picture, again, you've got a peritoneal lining of this abdomen. So what's going to happen when this passes through is going to actually take some of that peritoneum with it. And so now you actually have what is part of the peritoneum down inside the scrotum. That is what we referred to earlier as a tunica vaginalis. And you have parietal and visceral, just like we talked about before. And again, if you get a loop of intestine that actually gets entrapped in here, that is what you call an inguinal hernia. So I mentioned earlier about foreskins and prepuces. I went ahead and put a picture of both here because some people may not have seen one of the other type. So here you have a penis with the foreskin pulled over it, and here you have one that the foreskin has been cut away. So the prepuce has these tiny glands up under it that serve as a great breeding ground for sexually transmitted diseases such as the AIDS virus. So circumcision has been shown to reduce transmission of HIV, but really there's getting to be a lot more controversy about whether or not we should be circumcising children. Whether or not you're circumcised generally depends on whether or not your dad has been circumcised. So you'll tend to see it more often in certain parts of the country, certain cultures, but it kind of wanes back and forth. Right now, I think the latest numbers show about half the boys are circumcised and about half aren't. So, again, there's getting to be a little bit of a backlash saying that we should not be doing it. In fact, there are some groups that equate it to female genital mutilation, which is tremendously more extreme. So I'm not sure I'd even go there, but people do. But with circumcision, again, sometimes it's a religious decision, sometimes it's just a cultural decision. And there's a lot of misinformation that's been on both sides of the argument. There's actually been at least one case of a man that sued his parents for circumcising him. And it probably is true that when you have an area that's rich in nerve endings, that's meant to be covered up and then is exposed to constant abrasion by underwear and such, that you are actually decreasing the amount of sensitivity that particular part is going to have. So that's the basis for a lot of the outcry against circumcision. If you are the parent of a young boy that has not been circumcised, then you have to make sure that you stay diligent that he's keeping it clean and preventing the accumulation of smegma up under the foreskin, because you can end up with what's termed as a balanoposthitis. The male accessory glands that we're going to be talking about have several jobs. The sperm we'll be talking about shortly. What you're going to see is they basically are made of chromosomes in the head. The mid piece is nothing but mitochondria, and then this tail has a constant corkscrew motion. So they're burning a lot of energy, but they don't really basically pack a lunch. So they're going to have to get nutrition somewhere, and one of those places is going to be the fluids produced by the male accessory glands. Also, these fluids are going to assist in carrying the sperm with them and also helping activate them. One of the things we'll be talking about a little bit later is that the pH of the vagina is very low. It's very acid. I always use this term here because I was amused seeing this in a school, one of the old school film clips talking about the hostile vagina. But the pH for the sperm, for semen, is going to be alkaline. So basically these fluids are providing a buffering capacity for when the sperm meets the acid environment of the vagina. Make sure you know the term capacitation. Capacitation is a process that allows the sperm to become fully mature and able to swim. Make sure you know, this is an important point, that capacitation is not fully completed until the sperm hits the fluids of the female reproductive tract. It starts when the sperm is going to be mixing with the fluids of the glands. It's completed in the vagina. So the accessory glands I want to talk about, you have a pair of seminal vesicles, you have a single prostate gland, and then you have a pair of the bulbourethral glands. These used to be known as Cowper's glands. So the seminal vesicles will be your source of sugar. That's going to allow the sperm to have the energy for that corkscrew tail contraction that they have. You will have acidic secretion by the prostate gland, while both the bulbourethral glands and the seminal vesicles are both alkaline. So they're acting as a buffer and then also as a lubricant. So be sure you can identify these on a diagram. You have your seminal vesicles, you have your prostate, and then you have the bulbourethral glands. Just to refresh you on everything else, you have your testicle, your epididymis, your ductus deferens, and then here you have the corpus cavernosum, and then here you have the corpus spongiosum. And here you have the glans penis. Up here, remember you've got the bladder, and then here are the ureters going up to the kidney. And then you have the bowel back here. This, in case you don't know, is the pubic bone. Poor reproduction here, no pun intended. But looking down, again, here are your seminal vesicles, there's your prostate, and then there's your bulbourethral glands. So I have to mention here about prostate exams. Most commonly, what they're going to do, usually when a man starts hitting his 40s or 50s, they'll start doing a blood test called a prostate-specific antigen. And that is usually normal, I believe, is less than 4. If it's elevated, they're going to do a prostatic biopsy. Very commonly, they'll do a digital exam. They'll simply insert a finger into the male's rectum and palpate the prostate to make sure that it's not enlarged, to make sure it's symmetric or even on each side. So quite often what happens as a man ages, that prostate is going to enlarge, and yes, it could be cancer, but usually it's simply what they call BPH, which is benign prostatic hyperplasia. Let me split that word to get it all on here. So that simply means that it's enlarged, but it's not cancerous. There's some controversy on whether or not we should be doing prostate exams as frequently as what happens, especially as for the PSA goes, because you end up with a lot of false positives, a lot of biopsies that don't really show anything that's significant. Also, a lot of prostate cancers are such slow-growing cancers that a lot of times men opt not to be treated because the chances are high that they might die from some other reason, it's just simply old age, before they actually die from prostate cancer. So that's getting to be a little bit more controversial in the medical industry. So I included this little public service announcement here about prostate cancer, and I'll let you read it if you're interested. Be sure you recognize the term cryptorchidism. Crypt means hidden, and then orchid is the prefix for testicle. So Cryptorchidism is when the testicle is retained. It does not descend all the way into the scrotum. This can be unilateral or it might be bilateral, and the testicle might be anywhere from all the way back up inside the peritoneal cavity, or it just simply more often hidden in the inguinal canal. The problem is when you've got a testicle that's higher up, it's not in the scrotum, then the sperm will be maintained at a body temperature that's higher than the optimal temperature for sperm. So it's not going to be a fertile testicle. There's also been a definitive link between that and testicular cancer. So usually at the age of about 1, if that testicle is not descended, they will go ahead and try to surgically pull that testicle down. If for some reason it can't come down or is torsed, they will actually just go ahead and remove it. Men live quite normal, healthy, happy sex lives with just 1 testicle, and they're just as fertile as a guy with 2. The term semen is not synonymous with sperm because sperm are swimming in the fluid, which is the actual semen. So an ejaculate contains a sperm plus a semen, and that semen is made up of various components, enzymes, sugars, other carbs, and also substances that are slightly antibacterial in action. The volume of the average ejaculate is only 2 to 5 cc's of fluid, but they contain, if you look at this, 50 to 120 million sperm per cc. So you're looking at about, up to 500 million sperm per cc. So if you're looking at that times 5, you're looking at sometimes well into the billions as far as sperm numbers per ejaculation. Here are a couple of photographs of semen. One is at a lower magnification, one is at a higher magnification. And you can see, again, the example of the high number of sperm in a cc of semen. So I hesitate to tell you to do this because God knows what you're going to come up with, but go to YouTube and try to find a well-produced little video clip showing sperm motility, because you can have all the sperm in the world that are of totally normal morphology, but unless they're progressively motile, meaning they can progressively swim forward, they're not going to be able to fertilize an egg. So make sure you know the parts of the sperm. The head is going to be where you're going to be finding the chromosomal material. The midpiece is a series of mitochondria that provide the energy for the characteristic corkscrew motion of the tail. The tail is the only flagellum you'll find in the entire human body. So we talked early on about the difference between cilia and the flagella. And cilia are the hair-like projections on the outside of the cell membrane that will move things across the cell membrane, whereas the flagellum is going to be the projection that actually moves the entire cell itself. So again, the sperm does not pack a lunch, so it's going to have to get nutrients from the seminal fluid. Make sure you know that the sperm is not motile, and that it's mobile with a T in it. Motile until it gets mixed with the seminal fluid. And this is an important, very testable point here. Capacitation is not finished until the sperm is mixed with the fluids inside the female reproductive tract. Well, my dog is probably snoring a little bit too loud, so I'm going to go ahead and quit this for a while, and I'll pick up tomorrow on the next slide. Sperm production in men starts around puberty and continues until death. Unlike women who undergo a sudden drop in hormones and the lack of fertility that comes with menopause, men tend to have more of a long downward slope of hormone production. And as long as the delivery equipment works, then their sperm can often be used to fertilize an egg. Traditionally, we've always thought about the age of the maternal eggs being a problem. We all have heard about women's fertility after the age of 40 declining, and also after the age of around 35, and especially around 40, the chances of conceiving a child with Down syndrome or other such chromosomal abnormalities is pretty well known. Now they're starting to think that sperm from older fathers is also going to be linked with issues such as autism and other defects. It takes approximately 2.5 months for each sperm to form. And remember, this is happening inside the seminiferous tubules, which are inside the testicles. And we're going to be talking a little bit about meiosis. This is a YouTube clip showing sperm motility. Remember that motility is essential for the ability to fertilize an egg. So this actually shows it on several different magnifications. Let's revisit the term capacitation. Remember that occurs in the, or finishes occurring in the female reproductive tract. And if you want to get exacting on it, it's talking about changes that are made in the membrane of the cell, of the sperm cell, that affects the ability to have that twisting motion of the tail. So the term is designated as hyperactivity. Remember that mitosis produces two diploid cells, or daughter cells. The term diploid means that you've got pairs of chromosomes. You got half of each pair from one parent and the other half of the pair from the other parent. So you end up with 23 pairs in a diploid cell. Now, meiosis, you're going to actually be splitting that diploid into half, so you end up with haploid cells, which means you've got 23 single chromosomes. And the purpose of that is so when you join a sperm and an egg, you don't end up with an abnormal number of chromosomes. So we have two different phases of meiosis for a spermatozoa, and I've got some video clips walking you through that. So again, spermiogenesis and spermiation are simply two different phases or stages of sperm production. And during spermiogenesis is when the spermatid is still attached to the Sertoli cell or nurse cell. Spermiation is the period of time in which the sperm has broken free and is freely swimming in the seminiferous tubules. So here are a couple of YouTube clips about meiosis. In case these links are broken, simply go to YouTube and Google, or do a search rather, on meiosis. The only thing you need to know about meiosis for the exam is understand you're taking diploid cells, dividing them into haploid cells, and that process is referred to as meiosis. That allows the random recombination of chromosomes. For example, if you have two parents that have 8 kids, each of those children will have their own separate traits because of the random ability of those chromosomes to rejoin during fertilization. Here is a graphic from Pearson, if you want to go ahead and pause and take a look at this, and it'll run you through as a reminder of the differences between meiosis and mitosis, and this is showing you meiosis 1 and meiosis 2. So in men, you're going to end up with 4 individual sperm, all carrying varying combinations of the chromosomes. But with women, we'll be talking about this shortly, you'll end up with 1 egg that's going to be viable, and then you'll end up with 3 polar bodies, which are going to be small versions with basically no cytoplasm, and they're not going to be able to fertilize anything. So with men, you get 4 sperm. With women, you end up with 1 egg and polar bodies. So what you see on the side right here, you're actually looking at a cross-section of a seminiferous tubule. And these cells that you're looking at, these are all the Sertoli cells or nurse cells. These tinier spots are actually the head of the spermatozoon, as they're still attached to the nurse cell. So this is still spermatogenesis. So on this graph over here, what you're looking at is you're going from diploid cells, that's represented by 2N, that means 2 sets of chromosomes, and you're coming all the way down to 1N. So what you're looking at is you're producing 4 different spermatozoon through meiosis 1 and meiosis 2. Male hormones we've already talked about. Just to refresh your memory, remember the GnRH that comes from the hypothalamus, and that's going to cause the adenohypophysis, the anterior pituitary, to release the follicle stimulating hormone and the luteinizing hormone. Make sure you know for the exam that the interstitial cell is going to produce testosterone as a result of stimulation of LH, or the luteinizing hormone. Make sure you know that follicle stimulating hormone is going to influence sperm production. So there is negative feedback referred to as inhibin. There's also one that you'll see in newer literature called kisspeptin that is involved in the negative feedback. So let's move on to the female reproductive tract, and here is a list of the various things. Make sure you can localize on charts. So we'll start at the level of the ovary, the beginning of the uterine tube. That's going to be referred to as the infundibulum, and then we're going to have the ampulla, and then finally the isthmus, the uterus, this entire section here, the cervix, and then finally the vagina. The vulva will actually be your external genitalia. So here is this similar picture to what I had for the male, showing the location of the reproductive tract sitting in the pelvic cavity. And you see how it's leaning on top of the bladder. Again, if you've ever been pregnant, then that is why a late pregnancy really makes women want to run urinate all the time. And also, too, if you've had several children, sometimes you'll have problems with incontinence later because of the effect of the uterus going forward onto the bladder. So again, what you're looking at, ovary, uterine tube, used to be called the oviduct, the uterus there, the cervix you really can't see from this angle, vagina, vulva. The clitoris is interesting here because this is sort of a traditional view. They really think now that the clitoris actually goes further up into the wall of the vagina. So make sure you know that what you're looking at here is your bladder. Just like the testicles, the ovaries are surrounded by this tough white covering referred to as the tunica albuginea, and they're suspended from the abdominal wall in a piece of mesentery called the mesovarium. Sometimes it's referred to as a ligament, but it's just a thin sheet of flat mesenteric membrane. So here again you see the fimbriae. These are little finger-like projections of the beginning of that uterine tube, referred to as the infundibulum. Before we go any further into talking about anatomy, let's go ahead and look at some physiology here. So unlike the spermatogenesis, which will start in males around puberty, oogenesis actually starts back inside the period of gestation. So around 5 months as a fetus is you'll have early egg formation called oogenesis. So you have millions, if you see here, 6 to 7 of these early eggs will form, called oogonia, and then they simply stop. They sort of stay in a state of suspended animation until around birth. At that point, some of these will continue development to become what they call primary oocytes. So all the ones that are going to develop will continue to do so. When the baby is around 6 months of age, they should be at the point they're going to stay for a while. Most of these oocytes will go through a period of atrophy, which is known as atresia. They simply get reabsorbed. So by the time you hit puberty, you only have about 400,000. So it's really an amazing weeding down process. You start with 6 to 7 million, and then you end up with less than 500,000. So around puberty, this egg development is going to begin again around adolescence. And at this point, the female is going to start developing monthly spikes of follicle-stimulating hormone. This follicle-stimulating hormone, just like the name would imply, is going to stimulate some primary oocytes to go through meiosis 1. And that's going to produce what they call a secondary oocyte and a polar body. A polar body is what an egg would be if you removed all the cytoplasm. A polar body is not capable of fertilization. It's going to simply be absorbed back in the female body. And so whereas men will produce 4 sperm, women will end up producing 1 egg with the a complement of the half of the chromosomes, again, haploid. And then you'll end up eventually with 3 polar bodies. These do not have the cytoplasm. So I always jokingly say that basically the female is still once again left to bring the lunch, because remember, these sperm are simply collections of DNA and mitochondria, and they have no nutrition for survival after fertilization. So it's going to combine with the egg, and the egg has all the nutrition for the developing zygote. Make sure you get this point, that the meiosis II for the egg is not completed until after fertilization. And at that point, that's when you lose the second polar bodies. So again, once the female hits puberty, those cycles of GnRH are going to begin from the hypothalamus. That's going to signal a rise for a follicle-stimulating hormone. And then every month you'll have some of these primary oocytes that are stimulated to go ahead and mature to completion. And then I want you to know the term for mature follicle is a Graafian follicle. So you can think of the follicle as being the basket that carries the egg, basically. And at ovulation, that follicle ruptures and releases the egg. Now, I'm using the word egg, but it means the same thing as ovum, so don't get confused. So make sure you know that after the follicle ruptures, it's going to hemorrhage a little bit on the inside. It actually goes through a few stages. The first one will be a corpus hemorrhagicum. Then it turns into another stage. It goes through corpus albicans, and then finally becomes corpus luteum, which means yellow body. That's a little bit more than you need to know, but you do need to know the term corpus luteum. The corpus luteum is important because it's going to be producing progesterone. And make sure you remember that is going to be triggered by the luteinizing hormone coming from the pituitary. So make sure you know pretty much everything on this page here. Now, sometimes the follicle won't ovulate, and it will simply fade away through the process of atresia. So what you're seeing on here, and on an ovarian ultrasound, you'll actually be able to see different stages of different follicles. You might see a corpus lutea, you might see several increasing follicles of different sizes as they sort of line up getting ready to go. So you've got the Graafian follicle right here. Here you've got ovulation being represented, and then here you have the corpus luteum. And again, then you kind of side this as the corpus luteum is dying here, and it's going to be reabsorbed. Make sure you know that the corpus luteum is the source of progesterone that is stimulated by LH. And again, here's a classic test question, so I'm going to re-emphasize that the egg does not finish meiosis II until after fertilization. This is very different than what's happening with the sperm. So let's move on down now from the ovaries into the uterine tubes. At different times, these have been referred to as fallopian tubes, sometimes oviducts. These are tubes of smooth muscle that will be carrying the egg from the ovary to the uterus over a course of around 3 to 4 days. I do want you to know the parts, and the little catcher's mitt that is wrapped around the ovary is referred to as the infundibulum, and the little finger-like projections are referred to as the fimbriae. So you do have cilia. Then there, remember, cilia will be the little projections, the hair-like projections that will carry something across the cell surface. So you have cilia on top of the epithelium that's going to be lining this uterine tube. So you have the infundibulum, you have the ampulla, and then you have the isthmus that will connect into the body of the uterus. So again, this is smooth muscle, and so you do have peristalsis here, propelling the egg toward the uterine body. If the egg is going to be fertilized, it's going to happen in the uterine tube. It's going to actually happen near the junction of the isthmus and the ampulla. And you have a very short time window for this to happen. It's going to happen typically within 24 hours after ovulation. The uterus itself is going to be suspended in what they refer to as the broad ligaments. Again, it's called ligaments, but really it's just a sort of a sheet of mesenteric membrane. Make sure you know the 3 layers. The perimetrium is the same thing as the visceral peritoneum. Hopefully you remember all that. So the myometrium is by far the thickest. That's a very muscular, smooth muscle, again, muscular wall. And then the endometrium is that very thin epithelial lining, and it's very rich in glands that will provide nutrition for a developing embryo. The cervix is a pathway between the uterus and the vagina, and you have an opening into the uterus, you have an opening into the vagina, so these are referred to as the internal and external os. So internal os leading from the uterus into the cervix. So this is a dorsal view, posterior view of the uterus. So what you're looking at here, you have the ovary, you have the infundibulum with little fimbriae fingers, you have the ampulla, and then you have the isthmus. And then we have the body of the uterus, you have the cervix, and then you have the vagina after the external os of the cervix right there. Your internal os would be here. And this is just demonstrating the broad ligament, again, a sheet of mesentery. This is showing you the myometrium. And then this lining is going to be the endometrium. And then on the outside of this, you've got the perimetrium. Be sure that you can identify these areas on an exam. Here is your lateral view, and once again, you're looking at the ovary, infundibulum, ampulla, isthmus, uterus, myometrium, cervix, the vagina, vulva, and clitoris. So remember, this is going to be your bladder. And that means this will be your urethra. And this is representing the colon in the back. The endometrium, although it's pretty thin, is actually an extremely important area. And because this is going to be the portion that's going to be nurturing the early fertilized embryo. So it's divided into two zones, the base zone, or the basilar zone, and the functional zone. The functional zone is the part you see all these little glands, and this is going to really develop and become richly seeded with glands in order to provide nutrition to that zygote, or the early embryo. It's also going to respond to changes even when you're not pregnant, as it simply gets ready just in case you're getting pregnant. And it's this part that's going to, if you're not impregnated, is going to slough off and be expelled as part of the fluid. This is simply the view that you see of a cervix if you look through a vaginoscope. And this cervix would actually be somebody that's getting ready to ovulate. It's going to be a little bit more engorged with blood. It's going to be more moist looking. Pregnant cervix, or one that's not capable of getting pregnant, let's say you're well beyond ovulation, it's going to be very tightly closed and be very pale and very dry looking. Here are a couple of photographs that show that. You can actually see a cervix that's pregnant, or in a pregnant person, it'll actually sometimes have a piece of tissue over the opening, so it looks like a finger over the top, kind of sealing that shut. And while we're talking about the cervix, let's go ahead and mention pap smears. These are cytology exams that have traditionally been recommended for anybody that's sexually active, basically. This is extremely outdated. Obviously, people are sexually active far earlier than that and also far later than that. Cervical cancer is more prominent in this age group, although I've had several students in their 20s that already had cervical cancer. Those are typically going to be linked to the HPV virus. Cervical cancer is much common in smokers and people who have more sexual partners, simply because those people tend to have more inflammation, vaginitis, cervicitis. So the HPV vaccine has been implicated in the vast majority of cancers. It's also becoming more commonly implicated in oral and throat cancers as oral sex becomes a more commonly accepted practice. So they do have some vaccines on the market, Gardasil, that sort of thing. There's actually one now that they're talking about that should be even much better than that. I actually had my sons vaccinated for it when they were early teens. Moving out of the cervix into the vagina, you're talking about having the urethra in the front and the rectum behind, so you can see a lot of complications that might take place during childbirth, or especially after someone who's had quite a few babies will actually have the stress and strain on the vaginal wall and vaginal floor muscles that can cause problems in those areas. So I put this picture in there as sort of a joke because I always was amused at the old videos that would talk about sperm venturing into the hostile vagina, and that always have Star Wars music. So anyway, that's obviously vulva normally does not have teeth. So a hymen is a piece of tissue that sometimes will cover the opening to the vagina. Typically, you think of young women who have never had sexual activity as having an intact hymen, but that's not always the case, especially for active kids, active young girls. Ride bicycles, climb trees, and that sort of thing. A lot of times the hymen is non-existent. So the vagina is going to have some glands that tend to parallel the glands of the male, except they're going to be much tinier, but they do still provide moisture and lubrication. So the female, just like the male, also has erectile tissue. In fact, it corresponds to the bulbar spongiosus muscle in the male. And then finally, the vaginal epithelium is stratified squamous. And one of the old ways they used to use to predict the fertility, trying to predict when ovulation is going to occur, would be to take a cytology smear and tell just how cornified those cells are. The closer someone got to ovulation, the more the body is ready for intercourse, and so the vaginal epithelium would get more cornified. So the pH is slightly low, so it's a little bit on the acidic side, and there's also a normal bacterial flora there. So douching used to be a very common procedure that women would do, especially after intercourse or after the periods. Now they realize that can be quite harmful, and unless you're being told to by your doctor, normally you really don't need to douche. There was a doctor, TV personality that used to use a phrase that the vagina was a self-cleaning organ, and it really pretty much is. Okay, and finishing up here then with the external genitalia. First off, this little fat pad that you'll see in front of the pubic bone is referred to as the mons pubis. And then the term labia translates to lips. So you have the inner lips, which are the labia minora, and the outer lips, which are the labia majora. So normally these are mucous membraned, and normally these are covered with skin. And then again, the clitoris is this little hooded structure at the front of the vagina. And again, the current theory is now that it does extend further up the wall, and what used to be termed the G-spot is actually basically an extension of that clitoris. Let's go ahead and give you a few terms here talking about post-birth here. Remember that it's going to be the prolactin from the pituitary gland that's going to cause the buildup of the mammary tissue itself. The term lactation refers to the process of giving milk. Colostrum is the very first milk that's given, and it's very low in fat and high in protein compared to the later ordinary milk. It also contains antibodies, in particular secretory IgA, that will stay inside the baby's digestive tract to help fight off infections there. So again, remember prolactin, and then also remember the oxytocin that is going to be secreted by the pituitary. Remember, it's going to be manufactured in the hypothalamus, secreted by the pituitary. The oxytocin is going to cause reflex of milk letdown. So prolactin is going to build up the tissue. Oxytocin is going to allow milk letdown. Just stepping through the later stages of development, puberty is defined by the beginning of adolescence. Adolescence is considered to be the time of transition between childhood and adulthood, and is thought of as being primarily the teenage years. It's going to be different from one culture to the next. So the average age of puberty in the United States is going to be around 10 to 11 years old in the United States and Europe, a little bit later elsewhere, and that's probably because our percentage of body fat tends to be higher than other countries. So remember, when I say 8 to 10, that doesn't necessarily mean when a period starts, but that's going to be the beginning of the hormonal changes to set that process up. This is happening earlier and earlier, and again, it's related to perhaps our fat proportion of our bodies, and also perhaps even the hormones that are in our food. You can actually sample a lot of the water in some of the sewage treatment plants, and you'll find really high levels of estrogens and progesterones that are in our water source from birth control pills. And also, you'll also in milk products, you'll find a lot of progesterone. Basically, cows are, as soon as they've had their babies, then they're going to be rebred as soon as possible so they can continue to develop that calf at the same time they're giving milk. So there's going to be hormones in that milk that you would not find in a cow that's kind of doing the normal cow life cycle thing if she were left undisturbed. So if you look at this, this is actually from a study in 1997, so I'm sure it's a little bit different right now. It's probably even the same, if not worse. But 13% of black girls and 1% of white girls were showing hormonal changes by the age of 3, and then 27% and 7% respectively by the age of 7. So again, it's pretty early compared to what it once was. The average age of menarche, or when periods started, used to in the 1800s in this country would be around the age of 17. Now it's backed up to 14, then 13, and now some kids are starting their periods 9, 10, and 11. A major problem for us as a society is that although bodies are maturing earlier, their brains aren't. So risk assessment is just not there in these really young kids, while the hormones and the sexual urges are. So a few more definitions here for you. Just use this word menarche. That's beginning of menstruation or periods. And again, you're around 17 in the 1800s. It's getting earlier and earlier. And the onset happens when your body fat percent hits around 17%. So let's go ahead and look at the menstrual cycle. Menstruation, or the period, is going to be the first few days of this. After that's over, you're going to move into the follicular phase. Ovulation is going to occur, and then you're moving into the luteal phase. So make sure you know what's happening during each of these phases, and make sure you know what hormone is going to be dominant. That's what we're going to be looking at in the next couple of slides. So I like this slide because it's talking about what's happening at the level of the ovary and what's happening at the level of the endometrium. So the period will normally be, it's going to vary woman to woman, but usually it's thought of as being around 5 days. And that is when you're sloughing out that endometrial lining and the blood that goes with it. And at that point, you're going to be starting over. And make sure you know this is referred to as a proliferative phase. And the hormone that you've got going on here is going to be rising estrogen. So it's called proliferative because this endometrium is getting thicker and thicker and developing the glands that would provide the nutrition for a fertilized egg. So this is happening as the follicle is maturing. So what you've got here going on is going to be FSH and estrogen. Around day 14 is going to be ovulation. And remember, when the follicle ruptures, releases the egg, it's going to become the corpus luteum. So this phase now is called the secretory phase. And the most important hormone here is going to be progesterone. So progesterone is going to be keeping this thick, rich, nutrient-rich, glandular-rich endometrium there just in case you get pregnant. So again, if you'll be getting pregnant in the uterine horn, in the uterine tube, and then a developed egg, a fertilized egg, would end up burying its way into this endometrium. If you do not get pregnant, what's going to happen, this corpus luteum, as it fades away, is going to stop the progesterone production, and then you're going to have rising estrogen production again, and this lining is going to dissolve away as a period one more time. Here you have the ovarian cycle lined up with the hormones, and again, this down here is talking about your endometrial lining. So follicle stimulating hormone, stimulating the follicle developing. The follicle is developing actually is producing estrogen. Ovulation, day 14, and then the corpus luteum is going to be producing the progesterone in response to the luteinizing hormone. So make sure you understand what's on this slide, that the estrogen is going to be in the proliferative phase, progesterone is going to be in the secretory phase. So if the pregnancy does not occur, then the corpus luteum is going to fade away, progesterone will go away, and once that endometrial lining loses that support of the progesterone, then it's going to simply slough out and be expelled. I thought I'd put this in here because I always get questions about birth control pills. They have really evolved in the last 40 or 50 years or so. They started out originally just progesterone as a way of making your body think it was pregnant. They started realizing that these high doses of progesterone and even with estrogen had some degree of risk with it, so the doses got lower and lower. So they prevent ovulation, and they can affect the mucus, and again, your body will often assume that it's pregnant. For a while, they had a pill on the market that was almost entirely estrogen, and estrogen has been implicated with things like uterine cancer, but in particular, estrogen is bad about causing strokes. So if you are even on the low-dose pills, and even though you may be on the ones that are a combination of estrogen and progesterone, if you are taking the pill, you should not be smoking. If you are a smoker, you need to quit anyway. It's really a sad thing to see women in their 20s and 30s with these really debilitating strokes that sometimes they don't recover from. One of the things I want to point out, picture that graph of what's happening at the ovary during your menstrual cycle, and you'll see that the estrogen level is rising as you get closer to ovulation. Estrogen puts you in a sexual mood, and so that's why you're going to be much more in the mood for sex around, days 12 to say, it's about day 17 of your cycle. Now, what happens, then your body says, okay, you might get pregnant, you lose the estrogen, you can start raising the progesterone, and that progesterone is going to make you very disinterested in sex. And so the old PMS term, that's where that came in from, because PMS meant premenstrual. So if you notice, that premenstrual cycle is going to be right smack in the middle of the phase that progesterone is under control. And so what this slide is saying, was kind of interesting. You don't have to worry about this for an exam or anything, but it's just saying that when you're on the pill, your libido is going to be down, and you might be subconsciously pairing up with men who would make a better father material than what you might if you were simply under the effects of estrogen and perhaps just looking not for a father figure, let's just say it like that. So as a quick review here, the hypothalamus is going to be producing GnRH. It's going to be the spikes of GnRH that will start to stimulate the production of things like FSH. FSH is going to stimulate development of the follicle, and the follicle will be secreting estrogen. After ovulation, you've got the corpus luteum, and that's stimulated by LH. Make sure you know the seal produces progesterone. So again, the whole idea behind progesterone is going to maintain that really rich endometrium that can sustain a fertilized egg or a zygote or early embryo. So when the progesterone is lost because the CL is lost, that lining fades away. However, in case you do get pregnant, that zygote, that tiny embryo, is going to be producing a hormone called human chorionic gonadotropin that will cause that corpus luteum to hang around. So that corpus luteum will then persist, and then later on in pregnancy, about 1/3 of the way through, the placenta will be able to make the progesterone from then on. But that corpus luteum has to stay in case the pregnancy is going to be maintained. So I put this slide in here just showing you sort of the negative feedback loop, all starting with hypothalamus, your GnRH affecting the pituitary, which affects the ovary, which is going to have an effect on the endometrium, and then there's your negative feedback loop there. And also, again, if you do get pregnant and have an embryo, then the HCG is going to feed back and maintain the corpus luteum, which will maintain that progesterone, which will maintain that embryo. We'll be talking about HCG again a little bit in the next chapter, but make sure you know that the embryo, the early fertilized egg, is going to be producing this, and it's going to cause the corpus luteum to stay around. and that's going to maintain the endometrial lining of the uterus, and that's going to continue on until around 3 months or so of pregnancy, in which the placenta will take over progesterone production. So again, make sure you know what's on this slide. Okay, so moving on through our lifespan here, let's go ahead and mention menopause. There's no set age for menopause. Some women might start it in their late 30s even, early 40s. Some women will actually start it in their late 50s to 60s. It's thought to have to be influenced by how early you start having your period. So the earlier you start, the earlier you reach menopause. The problem with this is that the female hormones will have a beneficial effect on things like bone density and even heart disease. So the earlier that you go into menopause, it puts you at a higher risk factor for osteoporosis and heart disease. So officially it's defined as a lack of periods for 1 year. But if you've ever had a hysterectomy or uterine ablation where you have no endometrial lining, you may be totally unaware of that change. You may end up having to have a blood test if you're so interested to find out, and you'll see a decrease in your LH and FSH that are going to cause a decrease in your estrogen and progesterone. This whole thing about hot flashes, certainly not a law that you're going to have hot flashes. Some people never have them. Some people are just plagued by them for a very short period of time. The problem is some women would have such serious side effects with, I won't say serious side effects, but strong effects with menopause, that they would seek hormone replacement therapy, and that was causing a whole bunch of problems as far as breast cancer and uterine cancer. The big study that they had, that they were using nurses to analyze every little aspect of their lifestyle, they actually saw such a big drop after they stopped recommending hormone replacement therapy that almost immediately became a pretty set rule for OBGYNs to recommend that only as the last possible option, and to use them for a shorter period as possible. Men, on the other hand, instead of having this very quick drop-off, men tend to have this more of a long decline. Usually it's noticeable in the early 50s. You'll see an actual 80% decrease between the ages of about 20 and 80. So you'll see a decreasing sperm count, and you'll see a decreasing libido, but the sperm are still able to be fertile. So we discussed that a little bit earlier, as far as they used to think that it was fine for older fathers to contribute to conception, but now they know that those older sperm can indeed have some deleterious effects on the embryo. Okay, let's finish up with a few terms here. Just make sure you know all the terms. Coitus, intercourse, and copulation all mean the same thing. A few more definitions here for you. Impotence is basically erectile dysfunction. Priapism is when it won't go down. You've heard in the commercials, I'm sure, for the erectile dysfunction drugs, saying that if you have an erection that lasts more than 4 hours, go to the emergency room. The problem is, you know now that an erection is a function of arterial tissue, and if you have one that's lasting for that long a period of time, you might actually end up causing damage, potentially even in the rare case, gangrene. Phimosis and paraphimosis have to do with non-circumcised men. Phimosis is when the foreskin is actually constricted around the end of the penis, so it's totally over the penis. Paraphimosis is even more dangerous. It's when you've got a constriction of the foreskin behind the head of the penis, and again, that can actually cause such damage to the end of the penis it could cause it to be lost. So both of those, especially paraphimosis, tend to be medical emergencies. And I just had to put this in here too, penile fracture. This happens a lot of times during sex when the penis accidentally meets up with the female pubic bone. So it will bend, and because again you're talking about tight arterial dilation up against that really rigid tunica albuginea that covers the penis, it's under high pressure, and so when it's hit with that much force, it can actually rupture. This is something that again, it's a medical emergency and has to be fixed. I always tell my class that they've actually had a study that penile fracture usually occurs not between a man and a wife, but usually between a man and someone not his wife. And they theorized that because the sex is likely to be taking place in a hurry and perhaps not in a bed. Who knows, it might be in the office broom closet or the back of a car, but it makes the positioning just a little bit more risky. So to finish up talking about guys here, the male orgasm lasts from 3 to 15 seconds. And while the erection process itself is under the control of the parasympathetic system, male orgasm is actually under the sympathetic system. So not always, but usually includes ejaculation. You have emission, which is the preseminal fluid that's meant for lubrication. And then after that, you have ejaculation. And then the detumescence is when the penis basically empties out from the blood and deflates. The refractory period is a period of time that's going to be necessary until the male can actually achieve an erection again. So the younger the male, teenagers, this might be a very short period of time. The older the male, it might be a period of 24 hours or longer. Now switching over to the female side of things, female orgasm is related to a very vascular congestion, so you have a lot of vascular filling and swelling. You do have a transudate that's produced for lubrication. What's going to happen, the vagina is going to narrow down, it's going to dilate at the top, and that's going to tend to want to pull semen. It kind of creates a vacuum because biology is doing everything it can to actually get you pregnant. The uterus will actually even change its position a little bit and lean backwards in an effort to receive that semen. Some women can experience what they refer to as ejaculation. And remember, these body parts are very similar in origin to a lot of those male body parts, so you can actually have some degree of emission of a fluid here. So the one thing you may notice is for women there is no refractory period, so that's why some women can actually achieve orgasms right after another and very close together. On the other hand, some women have issues with not being able to achieve an orgasm with normal vaginal penetration. And recent studies have actually shown that some women actually have a smaller clitoris than others, and that will give them more problems with sexual satisfaction. So that is the end of this chapter, and as a follow-up to talk about sex, this next chapter we'll be talking about babies.